So I'm going to go over a study we recently done in Public Health Wales, which is looking at the outcomes of an intervention called the All Wales Diabetes Prevention Programme. So this programme attempts to identify those who are pre-diabetic within Wales, and that's determined through an indicator called HbA1c, and that's derived from a blood test. Those who are pre-diabetic are identified as being at risk of developing type 2 diabetes. So based on a number of early pilots undertaken in Wales 4 to 5 years ago, Welsh Government allocated funding to Public Health Wales to share this funding with health boards in Wales to deliver the programme. It's a 30-minute intervention delivered by healthcare support workers and dietitians. Basically, those identified as pre-diabetic are called into a general practice, and this 30-minute intervention is delivered. The aim of the programme is to reduce blood glucose levels. So pre-diabetes is identified through having a HbA1c between 42 to 47. The aim of the intervention is to reduce that HbA1c, ideally to below 42, which would be deemed as having normal blood glucose levels. A second aim of the program is to reduce the incidence of diabetes. So, and that's defined as having a HbA1c above 47. So what we done was we worked with the AWDPP team during the design phase to kind of develop the data infrastructure. So we developed something called a data entry template that healthcare support workers could upload into general practice IT systems. This would collect a minimum data set that would then be recorded into an individual's electronic health record. We then use SAIL to access this primary care data and linked the Welsh longitudinal general practice data set with other data sets such as the Welsh annual death extract and the demographic survey, and I'm abbreviating that. So the design we used was a step wedge. This is because of how the intervention was delivered across Wales. It was delivered in different time periods. So the intervention was rolled out across all 7 health boards in Wales, although we only focus on 6 health boards, as one health board had a slight deviation from the intervention protocol. We looked at delivery of the programme from June 22 to June 23. Based on this, we included a 3-step model, which each step was introduced at 4-month intervals. In total, 59 practices are included in our study. And to note, Public Health Wales led this evaluation, although support was given by individuals within Swansea University's Diabetes Research Group. So we looked at a comparison group that was individuals within participating practices that were pre-diabetic before the program was introduced. We undertook an intention to treat principle. So we had 1,970 individuals who were offered the AWDPP, and we looked at outcomes 12 months post baseline HbA1c and looked at the outcomes against a comparison group, and that consisted of 1,494 individuals. The baseline HbA1c values of both groups were very similar. The majority of participants were female. Most individuals came from deprived quintiles and were within the, kind of the range of obesity groups was somewhat similar. And the average age was 64 to 66. Basically, what we observed within both groups was similar to what we observed within current academic evidence. So looking at the outcomes, we found no significant difference in either group reverting to normal blood glucose levels. Although there was no significant difference, those in the comparison group were slightly more likely to revert to normal glycemia. Then looking at remaining with pre-diabetes, at follow-up, those who were offered the AWDPP were significantly more likely to remain within the pre-diabetic range. As such, those who were offered the AWDPP were 26% more probable to remain within pre-diabetes in comparison to those in the comparison group, where those in the comparison group would have just received care as usual. In terms of progressing to diabetes, so this was our main aim really, and the aim of that of the AWDPP, the probability of people reaching diabetic levels was 23% lower in the group offered the AWDPP, so very promising results. When looking at relative risk, this means that those in the comparison group are 6.5 times more likely to progress to living with diabetic blood glucose levels. Now, we also looked at the probability of an individual within the group that were offered the AWDPP. What was the probability of them having a worsening HbA1c level at follow-up in comparison to the comparison group who received care as usual? The probability of those in the treatment group not having a worsening HbA1c was 23% higher. So again, very positive. We then looked at change in nominal blood glucose levels, and overall those offered the AWDPP presented with a lower HbA1c of 1.1 mmol. And although this is modest, it still shows that the AWDPP is effective in reducing the risk of those who are pre-diabetic progressing to type 2 diabetes. From this, we have sent a recommendation to Welsh Government that the AWDPP continue to be funded and expanded throughout Wales. So at the time of this study, we looked at the first year of delivery, and although all health boards were receiving the intervention, not all primary care clusters were, so we suggest that further primary care clusters receive funding. What we also think is important is that we assess the long-term impact. So we only looked at 12 months post-baseline, and we know that for sustained change, we need to look at whether those reductions in HbA1c are observed over time. We also think it'd be useful to look at the economic return on investment of the AWDPP, as diabetes has a significant cost to the NHS currently. Data collection, I just think this is something to note, and the importance of SAIL. Without SAIL, we wouldn't have been able to undertake this evaluation. Hugh, who is on this call, and others within SAIL were pivotal in helping our team understand how we may access and collect data for this study. So it was vital to have that data collection resource at primary care that could then record data into an individual's electronic health record and subsequently be utilized in SAIL. And SAIL was so useful in, I suppose, upskilling our team on how recodes are used within primary care and how we may access them within SAIL. Just quickly, the strengths and limitations of this study. This is kind of the first time our team have used a step wedge approach. We believe that this adds rigor to our study design, as it kind of complements how the program was delivered throughout Wales, and kind of highlights how, although within public health we may not have full control on how interventions are delivered, we can slightly adapt kind of golden standard study design methods to kind of answer these complex questions. And just a limitation, as some of you may know, some data in primary care is not fully complete, so we weren't really able to control for BMI, for example, or ethnicity within our modeling, although this is something we'd like to do in the future. And just that our study relied on routine blood samples taken as part of routine practice, so there may be potential bias in our sample, as those who undertook routine blood samples may have done so for other conditions.